SuDT4. My name is Sunil Agrawal. I'm a professor of mechanical engineering at Columbia University. And the chair of the session is Professor Joel Stein, who is the chair of rehab medicine at Columbia University. A little bit about the schedule of the session. We have 4 speakers, and every one of these speakers is very well known in the field. We start out with Professor Joel Stein at Columbia, followed by Professor Preeti Raghavan from Johns Hopkins University, Professor Roberto Esquenazi, and Dr. Spungen. So we have about 20 minutes for each one of our speakers, and followed by questions and answers. Please put your questions in the chat box, and we as session moderators will decide whether we want to take these questions during the talk or at the end of the talks. But please do put in your questions. So it is my pleasure to invite Dr. Joel Stein to start the session, and I'm going to unshare my screen and let him share his screen.
Thank you, Sunil. It's really a pleasure to be participating and discussing hopefully some of the clinical opportunities in robotics. Can everybody see my slides okay here?
Yes.
Okay, very good. Thank you. So I titled my talk Matching the Designs to the Clinical Needs. And what I really want to do with this talk is spend a little bit of time discussing some of the other opportunities for rehabilitation robotics. I think that there's been a little bit of a narrowness of focus on some of the most common disorders and a select group of problems that I think has left a lot of issues unexplored. So this is really more of a clinical talk, if you will, on some of the common mostly neurologic disorders and other things that we see clinically that I believe are potential targets for rehabilitation robotics, but have not yet really been addressed much. So that's my goal for this. I have some research, none of which is really relevant to the contents of the talk. So what I'm going to discuss a little bit is what are some of the major clinical disorders that we see that are relevant to this topic, and what are their rehabilitation needs, and how might robots help us with these disorders. Discuss a little bit about what some of the barriers might be, and then future directions. So just a moment on sort of the growth of this field. I think we're all familiar with this. It is interesting to see that as the number of publications in rehabilitation robotics has gone up year over year, the interest in wearable and exoskeletal robots as a percentage of that has increased rather dramatically in the last several years. And I think that reflects an opportunity for wearable devices, perhaps, for a broader array of disorders. This is just a map from clinicaltrials.gov showing where the clinical trials are happening, which are focused based on this data largely in the US, Europe, and China, although not all countries really participate in this US database. And so Japanese studies, for example, are probably not well reflected here, or Korean studies, because I don't know that they use it as much. I'm going to break down the clinical disorders where robots may be particularly helpful into 3 major groups here. The first is orthopedic disorders. I'm going to spend only a couple minutes on that, and then mostly talk about neurologic disorders with various motor components, and then touch on some of the issues that we face for neurologic disorders that are not primarily motor, but may be amenable to robotics in various ways. In the orthopedic arena, there really has been remarkably little effort that I'm aware of to develop robots for some of these conditions, one of which is extremely common, which is osteoarthritis and other forms of arthritis. This is a very painful condition. We have limited medical therapies for it. There are medications we use to mitigate symptoms, yet our only sort of surgical option are joint replacements, and those are rather invasive surgeries. And it would be nice if we could develop devices that could unload some of these arthritic joints, particularly weight-bearing joints, in ways that enhanced function and maybe gave us another option in between medications, injections, and then on the other end, surgery. We also haven't really seen a lot of robots designed yet for joint replacement surgeries. These are extremely common surgeries. These patients have significant rehabilitation needs post-operatively, and yet there hasn't been a lot of work there. And then there's a little bit of work in scoliosis. Actually, Professor Agarwal has done some of that work. But I would say in general, it's been an underappreciated opportunity, and it's complicated. These are all complicated disorders. Certainly scoliosis is an area where bracing has both pluses and minuses. Strengthening muscles has also a very important role, and perhaps robots can be used to strengthen some of those muscles and to mechanize some of the physical therapies that we have for this disorder. Some of the strategies we might use for robotic devices in orthopedic conditions include range of motion exercises, for example, for post-joint replacement patients. A very important part of their recovery is moving the joint through the full range of motion, or as much of it as they can. There are some electromechanical devices that do this, continuous passive motion devices, but there is nonetheless very limited research to date on more sophisticated robotic devices. Strength training, again, a lot of electromechanical devices for this and simple mechanical devices, but there may be a role for more sophisticated devices. We touched on spinal orthoses, and then unloading pain-generating structures, in particular arthritic joints, I think is an important opportunity, and as my joints age, perhaps more personally relevant than it once was. Switching gears now to talk a little bit about the neurologic disorders that we face. These are, I've highlighted and read the ones I'm going to touch on today. Certainly stroke, cerebral palsy, spinal cord injury have really been the focus of the vast majority of the research in rehabilitation robotics. I'm going to skip over some others, in particular traumatic brain injury and multiple sclerosis, basically because of the variability of those conditions and the overlap of some of the issues that people face with some of the first three. But I also want to touch on Parkinson's, a little bit on the dystrophies, and ataxias, tremor, neuropathy. These are all important disorders and conditions that really haven't gotten as much attention in terms of robotics. I'm not going to spend a lot of time on these, but I do want to mention that there are non-motor conditions that we might think about as having opportunities for robotic devices. There's certainly a growing prevalence of dementia in this country. It's not a motor disorder predominantly, but it certainly does result in falls and reduced mobility, and also the need to keep people safe. Seizures, again, could robotic devices keep people safe in certain conditions, keep them from falling and injuring themselves, are interesting to think about. And then there's a significant number of people who have sensory loss, either due to neuropathy, certain types of stroke, and as a result become unsteady often, have limited mobility or use of their upper limbs because they can't feel things, not because they lack strength, and whether there are ways to mitigate some of those symptoms with more sophisticated devices that perhaps include sensing as well as possibly motor components is worth thinking about. In terms of stroke, there are about 800,000 new strokes annually in the US, about 7 million stroke survivors, and many have reduced mobility and a significant percentage with reduced arm function. And this is sort of the 600-pound gorilla of neurologic rehabilitation because it's such a common problem. And it's certainly what I've dedicated most of my professional life to addressing. But I think the large size of this sometimes obscures some of the other opportunities in other areas. This is patient, all these videos I should just mention are clipped from the internet. None of these are my own patients, and I hope that they were put there with the patient's permission, but I can't swear to that. But this is a gentleman who has a fairly classic hemiparetic gait. You can see he has difficulty dorsiflexing his ankle. He hyperextends his knee. He doesn't really have good knee flexion, and he circumducts as well. It's a very classic hemiplegic gait, and presents multiple deficits that are challenging. And obviously many people, including many who are participating in this session, have been working to try and fix. The arm similarly is again familiar to everybody. These are some of the deficits that we see in terms of reduced motor control, as well as reduced strength. You can see he has difficulty grasping the objects, maintaining grasp, and in positioning the arm appropriately to acquire and drop off the items. And again, we've heard a lot in other sessions, and there's a lot of work on the hemiparetic upper limb. It's certainly an important and challenging topic, but it's not the only thing we see. Here's cerebral palsy, again, a very common disorder. You can see about 750,000 affected individuals in the US. Most have spastic CP, some have mixed, and some have what's called athetoid CP. And most people with cerebral palsy can walk, but certainly some are non-ambulatory, and a percentage are ambulatory with a device. This is a child with diplegic CP. You can see moving with sort of typical gait pattern here, and you can see with various braces in place and at different ages. But the challenges that these children face are again, one of both weakness and reduced motor control, reduced balance as well. And there are a variety of strategies that are already underway to try and address these needs, although I think that because of the challenges presented by working with children, certainly not as much here as you see in the stroke field. Athetoid CP really hasn't gotten much attention, and I think that there's opportunities here. These difficulty controlling movements here are very different than in spastic CP, and you can see this child's difficulty with reaching movements, which are fairly characteristic. There are involuntary components to these movements as well, and whether we could assist children like this in restraining involuntary components to their movements and help them acquire targets is something that I think deserves some thought. I'm going to show you later also people with ataxia who have some similar issues. Just touch on spinal cord injury briefly. This is a paraplegic person who is walking with an exoskeletal device, certainly familiar to all of us. I think that I'll skip over some of the challenges these braces face and want to talk a little bit about Parkinson's. Parkinson's has a number of gait deviations. This person has reduced step length. You can see they have some slowness and particularly some difficulty with turning. This is a sort of a moderately severe impact. Patients with much more severe Parkinson's may actually freeze and be unable to continue their walking, have a high risk of falls. This is somebody who has a freezing of gait, and you can see the difficulty they have when they literally get stuck. And again, we haven't really developed robots that would be as helpful for here as I think we might. There are ways to help people initiate gait again, and I think opportunities for smart braces of various sorts to give the right stimuli to hopefully help people overcome some of their gait freezing and resume walking. There are other techniques that are used, for example, a line on the floor. There are laser pointers people will use to project a line for someone to step over, which allows them often to resume walking. Do want to mention Duchenne's as another pediatric disorder. This is a fairly classic picture. That maneuver where the child is pushing up from his thighs is a classic sort of finding in Duchenne's. You can see the weakness. There's no spasticity here. Motor control is not impaired. It's really a question of weakness. And these are progressive disorders. There are treatments that are being worked on, but haven't yet had a big impact on the severity. This is called the Gower's maneuver, where the patient actually sort of uses their arms to climb up and to achieve an erect posture. And I think, again, we could be doing more for these children to try and develop devices that would be helpful for this diffuse weakness without motor control problems, without spasticity. But it is progressive, and that's something that needs to be considered in wearable devices for these type of children as well. And here's a child with more advanced. You can see the hyperlordosis in the spine, the characteristic toe walking gait. You can see they're keeping their knees fairly extended to improve their stability. You know, a child like this is close to the sort of margin of being able to continue walking. Ataxia is another group of disorders. There are multiple causes for this. It can be due to stroke. There are a number of degenerative conditions that cause this. There is a discoordination of movement, often a wide-based gait, and difficulty with placement of the limbs. I've been long interested in the opportunities for devices perhaps to help people control some of those movements that are essentially not well controlled, and allow them to perhaps achieve their targeted movements more consistently. Again, there's complexities with that. You can see this patient also has reduced balance and difficulty with turns and mobility in general. Can affect the trunk, the legs, and the arms. Here's a patient with a fairly characteristic wide-based gait, not as impaired as the other patient. Tremor is another disorder where, again, there's been really not as enough work in robotics, I think, as there might be. Patients with tremor you can see the shaking movement she has of her head, but also of the arm as she tries to apply lipstick here. This next scene is a patient trying to eat soup, and a very characteristic tremor that they have, which is probably an essential tremor in this case, and becomes very difficult in certain circumstances, and presumably could be moderated with some mechanical support. People have tried to develop some mechanical means to stabilize some of those movements, but they haven't really been effective, and I don't think they've really been fully developed in terms of the potential to develop orthoses that have a intelligent component to them. This is a somewhat simpler problem that we typically deal with bracing. This is a patient with Charcot-Marie tooth disease, which is a form of inherited neuropathy. And you can see this patient has a steppage gait. They pick up their feet high to walk because they have a drop foot on both sides. There are many other forms of neuropathy, but most of these are dealt with more conventional braces. But I think there may be opportunities, particularly as these become more severe, to think about more sophisticated devices that could be of assistance. And then this is a very challenging problem. This is a sort of geriatric gait with multiple causes. Presumably, you can see this person is walking very slowly with a somewhat hunched posture. They're using 2 canes for stability, probably due to a combination of sensory deficits, motor deficits, loss of vision as well, loss of proprioceptive ability, perhaps. This is a clip from the news in China. It's sort of not the strategy we'd employ in New York City, and certainly not during the pandemic, but it was sort of amusing to see how they dealt with this particular gentleman's problem. I think we can do better than that. So it would be nice to think about ways in which we might, for example, have more sophisticated walkers that are able to provide assistance, perhaps wearable devices as well. And then a lot of the work in robotics has been focused on exercise training devices, to some degree on assisted devices, such as for patients with paraplegia. But there is a need for robots who can assist people with daily tasks. And these could include feeders. This is actually a commercially available feeding device, but really there's not been as much work in this area as I think is needed. So this is not intending to train someone to eat, but to assist them in their daily task. This is a fairly, straight, it's not a terribly complicated device. I think the movements are sort of pre-programmed, and it's, I haven't seen it used much, but I think it has potential as a sort of strategy for other applications as well. These wheelchair-mounted robotic arms have not really seen much broad application, not because they're not sophisticated from the mechanics, the degrees of freedom, but because the control mechanisms are too laborious. And these require people to essentially navigate through three-dimensional space in ways that require a lot of attention and effort. If we could make these more intuitive and easier for patients to, for example, identify, a cup and bring it to them without needing to navigate as in as many steps, I think that would be a really a boon for patients with severe disability. And brain-computer interfaces, of course, and robotics that are somewhat autonomous have a lot of potential as means of helping people around the home in a way that we still have a lot of work to do in this. I think there is a decent amount of work here, but I think the the technological barriers are obviously still being figured out. And I do believe that the usage case from the user's perspective needs to be better understood. Of course, there's financial issues, and some of the neuroprosthetic systems really still have a long way to go. The other big challenge with ADL robots is that they don't typically eliminate the need for a human caregiver for these patients. They simply provide some increased autonomy in selected tasks, which is certainly still valuable, but doesn't necessarily reduce cost of, for example, human caregiver assistance that many severely disabled people need. And they do typically require, they have a high cognitive burden, so people have to be cognitively in good shape to be able to use these. These are not suitable for people who have cognitive issues typically. And then I just to mention the need for robots to keep an eye on people, to keep them company. Again, this is an area where there have been some commercial efforts in terms of robotic pets, less, and certainly telemedicine, telepresence systems, but not really been thought of as so much of a rehab goal, but I think it should be. And I do think we should be thinking about, for patients with brain injury, can we develop robots that will provide supervision or remote supervision in some way, and perhaps provide cueing and assistance in daily tasks. And this is still an area that needs, I think, a lot more attention. So in summary, what I would say is that robotic applications are really focused on a relatively small group of disorders, in particular stroke, spinal cord injury, to some degree cerebral palsy, but really have left many of these other disorders relatively little studied. Each of them has unique clinical features. They require different strategies. And I think that what we need as a field is to start from the proposition of what is the disorder we're trying to treat, what are the specific impairments that are interfering with function, and what do patients want in terms of helping them regain function, so that we can build devices that are very specific to those needs. You see from the videos I showed just how varied the motor problems are that these people face. And I don't think generic devices are likely to work, or repurposing a device that was developed for one population for another. For example, there have been these wearable exoskeletal systems for the legs developed for spinal cord injury, and efforts to repurpose them for stroke, which I think are suspect from the start, because the device really wasn't designed for that purpose. And I suspect will ultimately prove not to be the right strategy, because it's not really specific to the needs of those individuals. So we really need to redouble our efforts to focus in on the precise clinical problems and precise clinical strategies if we're going to effectively develop devices that work for people. So I think there's a lot of unexplored terrain, and I'm hoping to stimulate some of the participants today to think about some of these other disorders. And maybe, there's the old joke about the drunk who is looking for their keys in the parking lot and continues to circle around the one light in the parking lot, despite the fact that it's a vast parking lot. And the reason that he provides when asked why he keeps looking in the same place is because that's where the light is. And I think if we're all clustered around one light, we're missing a lot of opportunities here and a lot of terrain. So that's my encouragement for the future. So I thank you for the attention. We have, I think, a minute or two if there are any questions in the chat box. I didn't, let me stop sharing my screen.
I think there is one question here, and the question is from Muhammad Bori and says, would you suggest that developments should be driven by rehab or activities of daily living?
So I think, I'm not sure if I understand the question precisely, but let me say that I think it's not based on activity. So for example, we don't need robots for dressing, right? We don't need a dressing robot or a feeding robot per se. We need a taxi robot for the upper limb, or we need a Parkinson's robot for gait assistance. I think it's a combination of the disorder and then the impairment that we're specifically trying to address that really should drive our thinking. So I hope that answers the question.
Yeah, thank you. So if you want, Joel, maybe we can go on with the next presenters.
So the next speaker is Dr. Preeti Raghavan, who is at Johns Hopkins University. And welcome, Dr. Raghavan.
Thank you, Dr. Stein and Dr. Agrawal. It's great to be here. Thank you for having me. Just going to share my screen. You see my screen?
Yes.
Okay, thank you. So thank you for the great talk, Dr. Stein. I'm going to sort of take off from where he left off and talk about sort of the big picture, a framework for designing and deploying technology, but specifically in stroke rehabilitation. I would like to disclose that I'm the co-founder and scientific advisor of a company called Mirrored Motion Works, an inventor of technology from NYU called the game-based sensory motor rehabilitator. And I'll be showing just a few results from a study in collaboration with Columbia, where we have a contract for a device. So I just want to share with you the current model of stroke care and why it's really not adequate for taking care of patients the way we would like to, and how technology and robotics can actually assist us. So basically, when someone has had a stroke, they tend to be shunted to many places. Initially, they may be at the stroke unit in a hospital for about 4 to 7 days. And then depending on how impaired they are, they might go home and have a home healthcare agency take care of them, or they may go to an inpatient rehab facility. If they're really badly off, they may go to a skilled nursing facility. Eventually, you would expect that they'd all come to outpatient rehabilitation. But as you can see, there's so much shunting around that often in the early stages, the focus of rehabilitation is really on triage and transition of care and not on recovery. So that actually leads to huge challenges. There's lack of access to care that's centered on recovery. There's lack of core measures that you can take across the continuum that are meaningful to recovery. We often lose the patients when they're being transferred from any one of these centers of care. And basically, we lack a unified model for delivery of care that focuses on recovery. And in fact, one way to characterize the current model of care is by this inverted pyramid model, where the most impaired patients actually tend to get the least amount of time for rehabilitation, right? And the intensity of rehabilitation. Right? So because the kinds of people we take into inpatient rehabilitation is often those who have the potential to go home. Whereas the patients who really need a lot of rehab are the most impaired, and they tend to go off to subacute facilities. And we've all heard about the horror stories of what happens sometimes in these subacute facilities. So what we really need to do at a systems level is to right the pyramid. And I think we can do that cost effectively by providing the right intensity of treatment to the right individual and at the right time. But to do this, I strongly believe we need to partner with technology. Technology is one piece of the puzzle, and it must fit perfectly with clinical care. So how do we do that? Well, the current state, as I said, not only are there a lot of silos, but let's say once a patient goes home even, a very small fraction actually makes it back to rehab. Only 30% of those who require rehabilitation actually receive it. And there are various reasons for it. There's transportation, the caregivers are working, there's so many, people can't drive anymore. So the list actually goes on. Now, during the pandemic, telerehabilitation has really come to the rescue. And, we have seen the possibility of using telerehabilitation to address so many rehabilitation needs that we never thought could be addressed, right? Not only that, telerehabilitation and the reimbursement that it allowed has really opened up a whole new perspective. But for patients, like the ones that Dr. Stein was talking about, and for many of our stroke patients, just tele or audio video guidance is not enough, right? It's very difficult for somebody at the other end of the video to eyeball incorrect movements. And very often, this is not data driven. It's not very data driven even in our clinics, but at home, it's very hard to evaluate patients thoroughly and to ensure that the treatment we are providing them is really the right kind of treatment. But we know that there's no dearth of rehabilitation technology, especially for stroke, right? And there are all kinds. There is expensive assist-as needed technology, which can be used in facilities because they are very expensive. There are self-assist technologies, which are slightly less expensive, where basically the patient there isn't a machine or there isn't a powered device, it's self-powered. An example is the bimanual arm trainer. And then there are relatively inexpensive, compared to some of these others, devices which could be used in the facility as well as at home. And they use the Kinect, for instance, and video gaming to sort of monitor the movements and provide corrective feedback. And they can also record the movements and facilitate remote monitoring and telerehabilitation. So the question is, how can we use some of the available technology, or how do we design new technology that truly fills the gap in clinical care? I've been working with a number of engineering graduate students, and they have so many skills. They're ready to build according to the needs of patients, but very often there isn't a perfect understanding of really what the needs of the patients are. So one of my graduate students, Veena Jayashree Krishnan at the NYU Tandon School of Engineering, did a study where she identified gaps between the technology and the needs of patients and clinicians. And she used something that's a little unusual for mechanical engineers. She used a qualitative technique where she performed semi-structured interviews of experts in the field, so really rehabilitation experts, and then came up with a framework for how to design and deploy this technology. And what I will say is that when this framework was completed, we were actually just at the beginning of COVID, and we were able to really deploy technology along the lines of this framework. So I want to share with you the method and really how this framework was developed and how it could potentially help anyone who's trying to design rehabilitation technology. So, the first question was really, in terms of robotics, what do we have? What are the advantages and what are the disadvantages? So, as you know, the robots tend to be exoskeleton or end effector robots. The advantages are they can provide repetitive practice, assistance wherever it's needed, facilitate data collection, and also target rehabilitation based on impairment. So I'm actually I put a question mark there because I'm going to share some results with you in the next couple of slides. But the disadvantages of many of these robotic solutions are they tend to be bulky and heavy. They tend to be expensive, and often they need supervision. So they may not be suitable for use in the home environment. So this was a study that we did together with Dr. Agrawal, where he had designed the Carex robot, which is a cable-driven arm exoskeleton. And it could provide weight support and or path assistance. And the goal here was actually to see if patients if certain groups of patients might require either path assistance or weight support or both. And so we had low functioning stroke patients who were classified based on their Fugel-Meyer score of motor impairment. So the lower the score, the more impaired they are. And the higher functioning patients, had a lot of natural movements. And we also looked at each of these conditions in a subset of healthy people. So if you look at the control, so the task was really to draw a circle in the air, and the robot could measure the path and look at the deviation area, which was normalized. And so we got the normalized error. And what you see is that, there were three conditions. PA stands for path assistance, WS for weight support, and then the combination. And if you look at the y-axis and the time, the speed is on the x-axis, you see that control subjects, show a very small amount of error. There really isn't that much of a difference across these three conditions. Actually, with path assistance and weight support, they tended to be more of a learning curve, if you will, to reduce the error. It wasn't very different in the high functioning stroke patients. They also showed, more error than the controls, but in terms of speed, it was they were fairly fast. If you look at the low functioning stroke patients, what's interesting is even though they had much more error, the error decreased across the 100 trials for each of these conditions, which was very promising that, if you provide robotic training, even within one single session, even the high functioning patients the low functioning patients who are really quite impaired and couldn't draw a circle in the air without the robot can actually improve their performance quite dramatically. But what was most interesting was that path assistance was not really that different from weight support, and the combination was not necessarily better. So in other words, sometimes a lower tech solution, just weight support, may be just as good as, all of the mechanics required for path assistance. Right? So that's something to keep in mind, that sometimes less could be more. The other category of rehabilitation technology is game-based rehabilitation, which can often be combined with robots. And the idea here is to really improve the patient's motivation, provide real-time feedback, a score, even, especially if the score means something in terms of rehabilitation. And it too can provide repetitive practice and facilitate data collection. But the key problem here is that the movement inputs to the game should match with what we want to achieve and measure in terms of their rehabilitation. Right? So, for example, there are a lot of Kinect-based games, but the problem that patients with stroke have is in rotational movements, and the Kinect cannot measure rotational movements. So if a patient remains internally rotated and they, play the game without changing their movement pattern, that movement pattern may not improve. Second, the scoring parameters should be chosen carefully because they must be therapeutic. So if somebody can play the game anyway and get a high score, they may use all the wrong strategies, right? But you really want to make sure their scores are related to better movement. And finally, another category is home-based or tele-rehabilitation solutions, which the patient can potentially utilize at home. And the exciting thing now is that, we've seen that it can serve the population, especially if this type of reimbursement that we've seen would persist. It allows flexibility and accessibility, and eliminates the burden of travel, which is actually, quite a huge burden for our population. The disadvantages, as we've seen, is that many patients don't even have basic technology. And some of the technology may be too complex to operate by themselves. But most importantly, even with reimbursable tele-rehabilitation, clinics and hospitals do not have a business model to deploy technology. So it is not seamlessly integrated into clinical care. And that is actually a huge problem. So in fact, there was a paper in Stroke last year where the challenges to deploying rehabilitation technology are that the technology doesn't really fit the needs of the patient. And there's a lack of understanding of what the patients really need, their limitations, and what the clinicians are looking for. So basically, you need a framework that will put all of this together. And without a poor fit, the technology doesn't quite, it's a mismatched piece of the puzzle. So Veena created a set of 8 questions where she really asked providers, clinicians, what they thought the major barriers and challenges were, and why or why not, why the currently available technology did or did not actually help. So she recorded the answers to the questions and then used a grounded theory approach from Denson and Lincoln's book to do the qualitative data analysis, where basically you code the conversation and then you create analytical categories from which you derive themes. And so from this, it's actually very time consuming, but from this large data set, 4 themes evolved. One was, the technology must try to create a solution to the barrier of accessibility. The second theme was adaptability to patient differences, accountability, and then engagement with rehabilitation. So let me go into this in a little bit of detail. So accessibility really meant that patients were not even aware of the possibility of continuing rehabilitation beyond the little silo that they sometimes tend to be in, either as outpatients. They don't know that once they finish their outpatient rehabilitation that is covered by Medicare, that they can actually do more. And so there is a need to provide education. And I think in some ways, technology companies have done a good job because they advertise and they're everywhere. But there still could be a lot more that is done. And we need to do it, not just technology developers, but clinicians need to incorporate technology solutions very early on in the rehabilitation process and educate patients about how it could help them. The second barrier was lack of time and staff to provide rehabilitation. So once again, it came down to what could be done very early on. While patients are still in the hospital, we need to actually introduce the technology to them right then and help them understand how to use the technology, involve their caregivers in education while they still have the opportunity to interact with the clinicians. And this way, once they're educated, they may be more confident to take that technology home and use it in a tele-rehabilitation environment where they could be supervised virtually. And then the cost of rehabilitation is often a big factor, but what I'm arguing is that you can reduce the cost of disability by providing rehabilitation early. The next theme was adaptability, where again, you could incorporate different training principles. You've got to be able to create rehabilitation technology that broadly supports patients with various cognitive, motor, and sensory issues. And there are many ways that could possibly be done. The third is accountability, where it's really important for the provider to know that the patient is participating and is adhering and is compliant. And finally, it's engagement. This is where gaming comes in and can play a huge role. But besides gaming, there could be other ways to engage individuals. So the framework that came out was the A3E framework for accessibility, adaptability, accountability, and engagement. And it goes very well with the entire ICF classification of disorders, where not only do you have to take into account impairment in body structures, in function, but also in participation. You also have to take into account environment and personal factors. So technology must also take into account that there's the medical model where you have to treat the impairment, but there's the education and the self-management model as well that is very important to keep in your mind when you're designing technology solutions. So one of the things that we've done is we've created risk stratified targeted care plans where we can use technology for the milder patients so that there's more self-management of their rehabilitation issues. Whereas for the more severe patients, you bring them in and you can use some of the larger robotic technology. So finally, implementing this framework can actually extend rehabilitation. And in the future, we may be able to create this erect pyramid where we're providing the most amount of care for the most impaired patients and actually reducing the cost of disability. So thank you very much for your attention. And I'd like to really acknowledge my collaborators in engineering, mostly, who've made this work possible.
Thank you, Preeti. That was great and really inspiring from the perspective of those of us engaged with these patients. It's so distressing to see people not getting the care they need. And there are studies showing very clearly, there have been some from Sarah Bernhardt studies showing that patients who are more severely impaired have less activity, not more activity as you would think they would need in rehabilitation. So really making sure that the level of rehabilitation matches the needs of the patient is a huge need. There was one question from an attendee. I think we can take one question and then we'll go on to the next talk. And that is, given where we are, how can we drive change here? I mean, this is a difficult situation. Everybody's trying to cut costs, and some of these care patterns are fairly well entrenched. So what can we do at a practical level to invert that pyramid?
Yeah, great question. Thank you. I really think that we need to talk more. We need to partner much more closely. When I say we, I mean the clinicians and the engineers. I think that very often, we're like two ships passing by. And I think that the big challenge is the business model. So we've got to figure out creative ways of getting reimbursement and making sure that whatever technology we are creating is, if it's part of a platform, that it could be used interchangeably, or that there is a way to incorporate it along the continuum. So, there isn't an easy answer. I think that's the space I'm working in to try to figure out a way to make this happen. But I think it's a challenge for all of us.
No question. Yeah, that's one of those questions you ask, and you're really glad you're the one asking it, not trying to answer it. So thank you. Well, very well. We're going to move on to the next talk, which is by Dr. Roberto Esquenazi, who is from Moss Rehabilitation Hospital. And welcome, Dr. Esquenazi.
Thank you very much. And thank you for the opportunity to be here with all of you. I'm going to share my screen. Hopefully you can confirm that you can see it. You're able to see my screen? Good. So my task is really more focused on gait restoration. And so I'm going to focus in that and really try to share a little bit of the data that it's available and exemplify some of the work that it's being done. Here are my disclosures. We have lots of collaborative approaches at the institutional level, but none of them are relevant from the point of view of personal financial disclosures. So the problem is not new. I think the idea of using technology goes back to about the mid-1800s. This is an illustration from that time where technology was trying to be applied to the process of rehabilitation. The problem is that we are dealing with population that requires a great degree of assistance, at least initially for their training. And as was elegantly shown by Dr. Agrawal in his presentation, these patients need a lot of help. You have many individuals trying to help them take just a few steps. And so that creates a big problem, particularly in patients with neurological injuries. As Dr. Stein suggested, robotic devices may be applicable in other arenas, but in neurological rehabilitation, we have the double challenge, one of the flaccid paralysis that presents initially, followed by the upper motor neuron syndrome, including spasticity and lack of motor control, which would remain in about 40% of the population that we see. And so what we've done over the years is focus on this idea that if we advance selective movements and we work on strengthening, there'll be some neurofacilitation techniques and patients will do better. But the reality is that we have very limited proof of that. And this came in great part because this fellow by the name of Ramon y Cajal, a scientist, a neuroscientist in Spain, who had come up with a concept that the brain was static and hardwired and was not able to change once it was in place. Of course, now we know clearly that the brain is plastic and that we can harness that plasticity, and we are able to really promote recovery through this rehabilitation interventions. And so as a result of that, we've developed newer rehabilitation principles. They've been around for a couple of decades, but it really talks about the idea of intensive, repetitive, and most important, task-specific training, which facilitates the function following central nervous system injuries. Of course, we want to be sure that we use large quantities of practice of this motor function, and that we include other factors that are critical to the recovery, including the emotional impact of the activity. I think Preeti mentioned the idea of enjoyment and fun, and how important is viewed by the patient. And of course, the role of rest, sleep, in some cases, brain stimulation and reward mechanisms to consolidate motor skills. So let me go back to this idea of framing the problem. And I think we heard a little bit of the discussion that in patients who have pretty severe disability, they tend to do very little. So this is an example of a patient who is admitted to one of our rehabilitation units. He requires moderate to maximum assistance for the activity of walking. And in this stay that lasted about 22 days, you can see that the patient had about 110 steps on day 2. This is using a stepping activity measure. On day 5, managed to do 34 steps. You can see that it went up to about 108 steps on day 7. And then on day 19, he managed to do 557 steps, then about 260, and then got discharged home. So there is no evidence here that these patients are walking more than in an average 500 steps. And this is out of 25 patients that we monitor in our units. And so really, we're not doing a very good job in providing this high intensity rehabilitation that it's needed for these patients. Of course, there are all these training principles that have been described with the idea of working on functional limb use, and that we really need to walk these patients. What we are trying to do is get them to learn to walk. But this types of programs have many limitations. It requires multiple therapists, as we illustrated. It is often limited not only by the patient's endurance, but by the therapist's endurance. It's very hard to sustain 10 or 20 minutes of consistent stepping, and the therapist can get injured. And here's an example of one of our patients receiving that kind of treatment. And you can see that the therapists are doing quite a bit of work. You wonder who's really doing the exercise here. 3 therapists, and they're all 3 working very hard with this patient. So robots really are a potential great solution because they are intended to help with tasks that would be difficult, unsafe, or highly repetitive for humans to do. And I've shown you, hopefully, that what we are proposing is difficult, it's highly repetitive, and it could be unsafe for the therapist. So robotic devices for rehabilitation are very appealing because they can deliver well-defined repetitive functional exercises, and they can do that in a consistent and prescriptive manner. Robotic devices can help individuals with severe weakness. We saw that illustrated by Preeti on the upper limb. Robotics can be very engaging, and because they're engaging, can reduce discomfort. Robots can progressively increase task, demand, and complexity. And although we don't have a well-orchestrated way to do that, it is possible to do it. And robots in the current environment allow physical distancing, which is something that we had never thought about in the past. But I'll show you some examples of that. So for gait training, I've categorized robotic devices into 5 major groups. Those that are tether exoskeletons, end effector devices, patient-guided suspension systems, untethered exoskeletons, and then joint-specific exoskeletons. And so let me illustrate that. This is a tether exoskeleton robotic device. This is the autoambulator from Motorica, or the most widely available, the Locomat from Hocomat. So you can see that these devices essentially have an exoskeleton that straps around the legs and then move the legs over a treadmill. Tether end effector robotic devices are slightly different. In essence, you strap the feet to plates that move, and then the patient is allowed to walk, and the movement at the hips and knees is really more free, except if you control the pelvis very tightly, that may be more constraining. But in general, the foot plate path is what determines the gait pattern rather than the exoskeleton, which is attached to the hips and knees. And here you have 3 examples of that: the Geo, the Lyra, and the Lexo. Then there are patient-guided suspension systems. Essentially, you're hanging from a device or the ceiling, and you're able to walk by having reduced weight bearing and permitting walking in this fashion. So this is what they look like. So you see a tether exoskeleton on the center. You see an end effector on the left side of the screen, and then you see a weight support on the right side of the screen. Then there are the non-tether exoskeletons. And so here you see 2 of them, which is what we have the most experience: the ReWalk, which was developed essentially for patients with complete spinal cord injuries, and then the ExoBionics, which is a system that has been determined to be used and approved for use in patients with stroke, traumatic brain injury, and multiple sclerosis, particularly in a hospital environment. It's a training tool where the rewalk is intended to go home with the patient. And then there are joint-specific exoskeletons. These devices are only working in one joint. And so here you see on the left side, the Restore, which is a soft exoskeleton, cable-driven, or the APO on the right side, which is a hip exoskeleton. Let me briefly tell you about the Restore. It's a device that, as I said, has an actuator hanging on the pelvis. There are cables that drive the system, which is anchored on the shin bone or the shin area with a soft strap system. And this essentially produces ankle plantar dorsiflexion on the basis of timing of walking. And you can optimize the control mechanism by having the brace produce dorsiflexion and the amount of dorsiflexion force that you want, or plantar flexion and the amount of plantar flexion force you want. So it gives propulsion in addition to raising the foot. So here's an example of a patient using this device. Right now the device is off, and so you see his foot is flopping up and down. Not dissimilar to the example that Dr. Stein had shown to us of a patient with a hemiplegic gait. And here's a patient with the system activated. So you have the actuator lifting the foot in dorsiflexion in the swing phase and then propelling plantar flexion, or using power to generate plantar flexion in the latter part of the stance phase. So it produces other improvements. It decreases knee hyperextension or knee stiffness. And here's just a quick example of how his temporospatial parameters of locomotion look. He walked with the system off at 0.80 meters per second, but with the system on at 0.99 meters per second, a fairly substantial increase in speed. And there are some improvements in step length and the fact that now he has a heel strike as depicted in the red foot prints. He now is able to produce a much better gait pattern. And so here are the results. This was a trial on 44 subjects, which had primarily patients with ischemic strokes. 41 of them were right hemiparetic, an average age of 54 years, 7 years post-stroke. And what we did is we essentially provided them with an average 92% assistance for plantar flexion and 62% or 63% for dorsiflexion. And then they walked for about 5 hours or 5 times plus 2 hours. And with this, they gain about 10% in their walking velocity post-training without the device. Now we know that improving walking function is a very important goal for rehabilitation. And really one of the primary concerns when you talk about social and vocational reintegration for a person with a neurological problem. And robotic devices for the lower limb gait rehabilitation have been really designed as a way to automate repetitive labor-intensive training, as we mentioned before. And really what we need to think about is that these patients need to have this high number of repetitions, need to be able to do it safely while balancing between accuracy and variability of movement. So let me go back again to the example of a patient that we tracked during walking. And so this is again a typical patient in our inpatient rehabilitation unit. And you can see that the difference of interventions. So this patient was allowed to have a suspension or a weightlifting device on days 4, 8, and 14. And so you see an increase in the number of steps, not substantial, but an increase. On day 21, the patient practiced with the andago, the door frame that I showed you that the patients can walk with a lift of their body. And then on day 28, he practiced for 15 minutes on a locomat. So you can see the huge difference that this can have. Now, this is important because what you're looking at is that the patients that walk in our conventional training program are walking, as I said before, about 500 steps. Those patients, when you put them in on a locomotor training program or others that you put there, you can increase the number of steps to nearly 1,700 steps per day. So by doing just that, you can increase their functional index motor gain, the measure of functioning during walking, by about 20 points. So you can see that tripling the number of steps you take has a significant impact in what your outcomes are going to be from the point of view of your ability to walk down the line. So this is a fairly important case. So as a result of this, we decided to develop a trial in acute stroke rehabilitation patients. And so we randomized patients to either giving them just additional training through a therapist, what we called supplemental conventional therapy, or robotic lower limb exercises. And so what we wanted to do is there a difference when we test these two groups? And so here you see the therapy assisted group on the left side depicted on 3 different images of what patients were doing versus walking on the locomat several minutes at a time. And we essentially gave them equal amount of training time. As you can see, we randomized 30 patients, 15 went to the locomat, 15 to the conventional group. Except for the age range, which was a little bit younger for the conventional group, the groups are very symmetrical. And the point of start, the acuity of their stroke was the same, about 17 days. And these patients receive a little bit more conventional treatment, about 12 hours, compared to the number of locomat hours, which were 8.3. Again, what we were able to prove is that when you walk these patients more, which was the case here, they have better outcomes from the point of view of FIM score. Let me just bring you to the last point, which was that robotics for gait rehabilitation actually can be useful, particularly now during COVID. So you see here 2 scenarios when we're training a patient in our Lyra system. The therapist can mount the patient on the Lyra system and then stay apart from the patient, reducing the need for close contact with the patient, even though everyone is wearing appropriate PPE. The same is true here, this patient on the right side using the Andago device, and the therapist can remain away from the patient without having to be in close contact for more than just a few minutes to do the setup. So I believe that rehabilitation technology really enables us to optimize treatment. And to do that, you need to apply it really in an everyday neurorehabilitation clinical practice. A little bit of what Preeti was talking about. The multimodal combination approach of traditional therapy and robotic gait training seems to work very well. And clinicians make application decisions using really their knowledge of motor learning principles, biomechanics, and neuroplasticity, and that there is an opportunity here to develop machine learning to really enhance what we are doing. And there are some efforts in that regard. There is the Arctic project going on, collecting data in hundreds of patients who walk on a locomat to try to see if we can come up with an algorithm to address that. I just wanted to share part of our ambulation guidelines. So here you see that these are for acute patients with neurological conditions, and how our therapy group has developed this algorithm that allows really the movement through all of the different devices that we have available to train patients in gait rehabilitation. And the end result is really to be sure that these patients end up being able to go home at the highest level possible, and then follow in outpatient therapy or in a home training program, again, as Preeti has suggested. So let me summarize by saying that ambulation is an important functional goal for our patients. It can reduce comorbid conditions and improve quality of life, and certainly life satisfaction. There is evidence to support the utility of robotic devices for gait rehabilitation in stroke and other acquired brain injuries, even in chronic state. And I truly believe that robotic systems do have many limitations, and as you can see in their design, many differences. But even with that, they are very useful tools that we should be able to integrate in our clinic. Let me acknowledge my group of collaborators at Moss Rehab and the Moss Rehabilitation Research Institute, and thank you for the opportunity to present today.
Thank you, Alberto. That was great. I want to remind everybody that the chat box is open, so please, to the attendees, feel free to add your questions now, and some we may be able to address now, some we'll address at the end when we have the panel discussion. I have one question for you, Alberto. In terms of the LEAPS trial, so this was a trial of locomotor training that obviously was larger than most, obviously didn't include all phases of care, didn't include necessarily the same population that you looked at. But how do you interpret those results, and what do we learn from that relative to some of the other studies? Is it flawed? Is it maybe too narrowly? Maybe we should view it more narrowly.
Yeah, I don't think that the trial was flawed. I think that it was well thought out, but it was in patients who were quite chronic, and what I've shown you are patients who are quite acute. So very different populations in that sense. And we try to be sure that both groups receive this additional care. And the point that I'm trying to make here is that it doesn't really take very much more than what we are routinely doing. We just need to be sure that it is incorporated. It's hard to do in these acute patients because they, are really pretty affected. They are very weak. They don't have the stamina that we would like. But if you're able to push them, it does show a significant improvement.
Fair enough. Any plans, or are you aware of any plans to do a larger clinical trial in the early post-stroke population? It seems like the sort of thing that needs a multi-center trial. It's just too hard to recruit suitable subjects in any one center to really do a decent sized study.
I totally agree. We are proposing to do that. We hope that this data will serve as the basis to, which we need to have this kind of data, and then invite sites around the world that may have the capability of providing the treatment that we're looking for. These are difficult to do because for example, Europe tends to run much slower pace than we do, and their length of stay are much later and longer. So we would need to find partners in the US. So that restricts a little bit of the field, because again, you need to have people that have equivalence in instrumentation.
Great, fair enough, thank you. Well, wonderful, thank you for that. We'll have time again for a panel discussion at the end. Next is our last talk, which is Dr. Ann Spungen from the Bronx VA. And we welcome her to speak, I assume, about spinal cord injury. I don't have a topic in front of me.
Yeah, that's correct. I'll share my screen now, and we can. Okay, and let me turn it on. Can you see that okay? All right, great. Thank you, Dr. Esquenazi, for a wonderful talk on stroke rehabilitation. And it's very parallel to some of the needs we are seeing in spinal cord injury, as I know you're well aware. Dr. Agarwal, thank you for inviting me to speak in this session. And I hope to be able to share with everyone what we've learned in the last 10 years of exoskeletal assisted walking for individuals with spinal cord injury. We've been fortunate to get lots of funding from the Department of Veterans Affairs through the Cooperative Studies Program, through the Rehabilitation Research and Development Program, from the Department of Defense, the Spinal Cord Injury Research Program, and the institutions that perform these studies also contributed support for this. No industry support was provided for this research. So, in 2007, Aaron Dollar and Hugh Hare wrote a very nice state-of-the-art review of active orthoses for the lower limbs and their challenges. And I highly recommend everyone reading this. However, since 2007, we could certainly use a new review. There are some out there of some of these devices, but at the time, this covered what was available. Then, around 2009, 2010, I wasn't sure exactly when, 2 pilot studies were conducted, one at Sheba Medical Center in Israel and one by Dr. Esquenazi at Moss Rehabilitation in Philadelphia. And this was the first study using exoskeletons in people with spinal cord injury in the United States. And they used the early version of the ReWalk for this study. In 2011, we received some funding from the VA Rehabilitation Research and Development Service to do a pilot study with the ReWalk at the James J. Peters VA Medical Center in the Bronx. And in 2012, the first 2 papers were published, one by the group in Israel and the other by Dr. Esquenazi's group in Moss Rehabilitation. And this group reported a high degree of performance variability, velocities of 0.03 to 0.45 meters per second. And this was using the ReWalk in both these trials. And they also noted that some participants reported reduced pain and spasticity and improved bowel and bladder function. Then in 2014, the FDA in the United States established a Class II market indication for powered exoskeletons. And the ReWalk was approved for institutional and personal use in individuals with spinal cord injury. In 2015, the Department of Defense funded our group at the Bronx VA to do a 3-site randomized clinical crossover trial. Enrollment was from 2015 to 2019, and I'll be sharing some of that data later. Then in 2016, Indigo was approved for institutional and personal use. And then the ExoGT was approved for institutional use. This is all for spinal cord injury. And also that same year, the first Cybathlon occurred in Zurich, Switzerland. And for those of you who may not be familiar with the Cybathlon, it's a multi-sport international competition event in which people with physical disabilities compete against each other to complete everyday tasks using state-of-the-art technical assistance systems. One of the 6 categories is the powered exoskeleton race. And besides their actual competition, the Cybathlon offers a platform to drive forward research on assistive devices for everyday use and to promote awareness with the public. Then in 2016, also the VA Cooperative Studies Program funded a 15-site VA Medical Center trial of the ReWalk for home use in veterans with spinal cord injury, and enrollment was ongoing from 2016 through 2020. In 2020, the Cybathlon had its second competition in Zurich, but this time it was a virtual competition. And just a month ago, in 2020, the Centers for Medicare and Medicaid Services in the United States issued a code for personal exoskeleton use. This is a huge breakthrough because this means that there'll be potential for insurances and Medicare or Medicaid to cover some of these exoskeletons. And as reported by Dr. Stein earlier, by the late 2020s, there's more than 150 papers published relative to spinal cord injury in the use of the exoskeletons. So just as a brief literature review, most of the papers report walking velocities, gait characteristics, and engineering aspects. And the walking velocities range from 0.2 to 0.72 meters per second. In terms of the medical health related research findings, there's been reports of reduced body fat mass and increased lean mass. Weight bearing in the device is near 100% of total body weight. There's been improvements in trunk muscle activity, seated forward balance, and lateral stability, improvements in bowel management and function, positive energy expenditure effects, positive neuromuscular activation, body mechanics, and postural control effects. However, no significant positive bone changes have been reported to date. So I'll be sharing data from the two randomized clinical trials. The first one, entitled Exoskeletal Assisted Walking in Persons with Spinal Cord Injury, Impact on Quality of Life, is a 15-site study, as mentioned, with the VA medical centers located in the Boston, the Bronx, Richmond, Augusta, Tampa, St. Louis, Milwaukee, Minneapolis, Houston, San Antonio, Dallas, Albuquerque, Palo Alto, and Long Beach. The goal was to randomize 160 subjects. Half the group would get standard of care for 4 months. The other half of the group would get the rewalk in their home for 4 months. The second study was funded by the Department of Defense, was titled A Randomized Crossover Clinical Trial of Exoskeletal Assisted Walking to Improve Mobility, Bowel Function, and Cardiometabolic Profiles in Persons with Spinal Cord Injury. This is a 3-site study that was conducted at the Bronx VA, the University of Maryland, and the Kessler Foundation. And the intervention consisted of 36 sessions of EAW training with a crossover to 12 weeks of usual activity. When we wrote these two protocols, we were very concerned about the right eligibility criteria. Establishing appropriate eligibility criteria remains a challenge to provide the proper balance between who should be included or excluded in order to avoid risk of injury while concurrently encouraging successful use of these devices. So while exclusion criteria for common medical issues seen in those with spinal cord injury is straightforward to implement, exclusion criteria to mitigate the risk of a fragility fracture, especially for bone mineral density at the knee, were not so obvious. Thus, reducing the risk of fracture was a primary concern when establishing the eligibility criteria for our studies. The inclusion criteria was age between 18 and 65, height between 63 and 75 inches, weight less than 220 pounds. The height and weight are pretty much the standard height and weight criteria for the 3 exoskeletons that were mostly seen in the United States today. They had to have their spinal cord injury greater than 6 months. They had to use a wheelchair for indoor and outdoor mobility. They had to be able to hold the loft strand crutches or a wheeled walker with their hands, either with modifications or without, willing to participate and legally able to sign a consent. The exclusion criteria, these are obvious. All of us would certainly agree that if they have open pressure ulcers, they cannot be in the study. If there's limited range of motion at hip, knee, and or foot joints that is incompatible with the fitting of the device, they're not going to be able to be in the study. If they have non-modifiable contractures, severe spasticity, or severe concurrent medical health problems, or pregnancy. And there's a complete list of the eligibility criteria on clinicaltrials.gov for both of these studies, if anyone's interested. So, however, the bone-specific exclusion criteria was more challenging. We used, in the early 2000s, Doug Garland out of Rancho Los Amigos Medical Center in Southern California had shown that people with spinal cord injury who have less than 0.6 grams per centimeter squared of bone mineral density at the knee were at the highest risk of having fractures. So since that was the only literature available at the time when we planned these two studies, that's what we decided to use. We also chose a total hip BMD T-score of less than -3.5. And we also, any unhealed traumatic or high impact lower extremity fractures since SCI, or any fragility, minimal trauma, or low impact fractures since spinal cord injury. And a fragility fracture was defined as a low impact fracture that may occur under conditions such as, but not limited to, a fall from a seated position, during stretching or crossing one's legs, during a transfer, bumping the lower extremity, dropping a foot to the ground, a light object falling on the lower extremity, or any fracture that occurred without the person's knowledge of it occurring. Note that after a year into the study, for reasons you'll find out soon, we added bilateral foot x-rays to rule out pre-existing fractures as part of the exclusion criteria for both studies. DEXA scans were performed on all screened participants. There are well-established guidelines for measuring hip and knee bone mineral density. The knee requires special software that is available. However, note there are no guidelines nor any criteria for measuring bone mineral density for any of the bones in the ankles or feet. So going back to the VA cooperative study, which is our 15-site study for 4 months of home use, shown here is the enrollment data. The table represents the number consented, screened, and randomized from 2012 through November of 2019. And we published this in a design methods paper in contemporary clinical trials. We consented 397 subjects across the 15 sites. After that, 49 of them declined to continue in the study with screening. 142 by November were randomized, and 201, 50.6%, were screen failures. Most of the screen failures, 25.9% of those consented, were based on fracture history or significant bone mineral density loss at either the hip or the knee. The second biggest reason for exclusion was contractures, range of motion, and spasticity. That was 13.6%. 8.1% had medical complications, and an additional 8.1% failed the EAW basic skills test. And 7.6% were either too tall, too short, or weighed too much. And another 7.3% had a level of spinal cord injury that was exclusionary, or their neurological status made them exclusionary. 4.8% were excluded because they didn't have an available companion or their home wasn't suitable for them to have an exoskeleton. So of note, by February 2020, we had randomized an additional 19 participants for a total of 161 of the 160 that were planned. On March 13, 2020, 133 had completed the study. 28 were in various stages of the intervention or follow-up when the study was placed on an administrative hold due to the COVID-19 pandemic. At this time, we are still on hold, and a decision has not yet been made by VA Central Office whether we will be able to continue the study or we'll have to end it at the end of the year. Moving to the DoD study, fortunately, we completed this study just last fall before the COVID pandemic arrived. We have 187 potential participants who showed interest, were pre-screened. 83 were not eligible based on yes/no questions that basically dealt with the inclusion criteria. 104 were consented for full screening. Of those, 33 subjects were screen failures, 15% based on the low BMD or fracture history, 8% with schedule conflicts, 4% with contractures, 3% outside the weight or level of SCI, and then 2% with medical complications. We randomized 71 subjects, of which we completed 50 subjects with 36 sessions of exoskeletal assisted walking and 12 weeks of usual activity. Of those study withdrawals, the 21 subjects, 15% were for compliance, 10% for medical problems, 3% for schedule conflicts, and 1 lost interest. So we published our primary paper just a little bit ago, and it's recently been available through Frontiers in Robotics and AI. And in brief, we used 2 exoskeletons in this trial, the ReWalk and the EXO. And in the 50 participants who completed, 14 had tetraplegia, of which 13 used the EXO and 1 the ReWalk. And 36 individuals with paraplegia completed, of which 9 used the EXO and 27 the ReWalk. And I'm sure you're wondering how we decided who used which device. Generally, we found that individuals with higher cord, more complete lesions who have less trunk stability do much better in the EXO than in the ReWalk. And those with lower cord lesions and less complete injuries are able to use the ReWalk. So initially, the EXO, what we're looking at here is the total number of steps taken in the first 1 through 12 sessions, then 13 to 24 sessions, then 25 to 36 sessions for the ReWalk and EXO. The ReWalk is in black, the EXO in white. And overall, throughout the entire study, the EXO users took more steps than the ReWalk users on average. But one can see that the ReWalk users, while they are taking less steps initially, eventually catch up by the 36 sessions with the EXO users. And this is probably because the EXO triggers stepping and higher step clearance, so the users are able to take more steps earlier in their training. The ReWalk users need to learn appropriate weight shifting to trigger stepping and to clear the foot during the swing phase. So shown here are the results for the walking tests on the y-axis and sessions 12, 24, and 36 on the x-axis. The 10-meter walk test, the top panel here, is for velocity. The 6-minute walk test is for distance. And the timed up and go is an overall test for device handling, how well they can maneuver the device. On all walk tests, the ReWalk users, shown in the shaded squares, were faster and walked greater distances than the EXO users, shown in the X. However, while there was a significant main effect for improvements across sessions, there were no significant differences for neurological deficits shown on panel B. In other words, as an overall group, they got better from 12, 24 to 36 sessions in each of these walking tests, but there was no difference within for the subgroups of neurological deficit: complete tetraplegia, incomplete tetraplegia, complete para, or incomplete paraplegia. And if we look at the relationship of total steps for all 36 sessions with the 10-meter walking velocity, one can see that we range in around 8,000 steps to over 80,000 steps across the 36 sessions in the participants, and that those in both groups tended to, with those participants who were able to achieve more total steps in the 36 sessions, had faster walking velocities overall. This was a significant relationship in the ReWalk, and it trended towards significance in the EXO. So the ReWalk was the only device approved at the time when we began this study. The Indigo subsequently has been approved, but when we designed this study, the ReWalk was approved by the FDA for personal prescription. So we used the FDA velocity and distance criteria milestones for personal prescription to see by what session how many of those who did use the ReWalk were able to perform. And we see that the one incomplete tetraplegia met that criteria by the 12th session. The 20 subjects with complete paraplegia, 6 met both criteria by 12 sessions, and then 55% by 24 sessions. And then of the 7 incomplete paras, 2 29% made it by 12 sessions, and 43% then by 24 and 36 sessions. Now, with this 36 sessions of exoskeletal walking, what kind of adverse events did we have? And this is very important information that I'm really glad to be sharing with everyone. We had 8 serious adverse events that occurred during the study. 4 were possibly related, the top 4, as you can see, and 4 were unrelated to study participation. There were no serious adverse events that occurred that were classified as related. 6 of the 8 SAEs were resolved with the participants returning to complete the study. 1 participant was discontinued from the study because of an unrelated knee fracture due to a fall during the vehicle transport, and 1 participant was discontinued due to the patient presented at the beginning of the 3rd session with mild foot swelling, bruising, noted before beginning the session. We sent them for x-ray. The diagnosis was of a medial malleoli fracture of indeterminate age, of which the radiologist suggested that it was a probable pre-existing, and we withdrew the subject from the study. This fracture seemed to have occurred with standing and stepping in the exoskeleton, not from a fall. In terms of adverse events, in more than 2,000 hours of exoskeletal assisted walking across all 3 sites, we had 75 adverse events. The majority of these were related to skin abrasions and bruisings that occurred early on in the course of the study. We were learning to be better trainers, better fitters of the devices in that first year. And we learned from our mistakes. And once we had a better handle on fitting the devices, these AEs with skin abrasions and bruising minimized. In all cases, they were resolved and no one was withdrawn from the study of the 39 and the 1 possibly related. However, we had excuse me, let me go back. We had 2 AEs that were directly related to the study. 8 AEs that were musculoskeletal edema, of which 6 of them were resolved and the patients returned, but 2 were withdrawn. Then we had another fracture in the foot that showed there was no hospitalization, so the patient, it was not considered an SAE, and it too was determined to be of indeterminate age, and the participant was withdrawn. This was noted during the 4th EAW session, and it occurred without a history of trauma or a fall. Because of this occurrence and the ankle SAE fracture, that's why we added the bilateral foot x-rays, because we were worried that there were possibly pre-existing foot fractures that had been undiagnosed that became aggravated or reopened with the weight bearing in the exoskeletons. So in summary, there were no study-related serious adverse events. There were 2 study-related adverse events and 1 unrelated SAE and 2 unrelated AEs that resulted in the 7 study withdrawals. So right now, I want to have a discussion related to foot and ankle fractures. As pointed out, 2 participants in our study may have had previous undiagnosed fractures that were complicated from weight bearing and stepping in an exoskeleton. In the literature, there are 4 case reports that have detailed similar foot fractures during exoskeletal assisted walking. And similar to the fractures observed in our study, foot or ankle swelling in all 4 prior reports was noted early during training, with diagnostic imaging confirming the presence of fractures. None of these fractures were the result of trauma, but appeared to be caused from standing, weight-bearing, walking, stepping in the exoskeletal devices. As such, these fractures were likely fragility fractures, and if not, pre-existent occult fractures at the time of injury. Moving on to knee fractures. We had no knee fractures in our study, but it's very important to note that the forces generated at the knee during the sit to stand transfer are much greater than the forces weight bearing when standing and walking. Some of the most severe reports of fracture in the literature and from the FDA website occurred at the knee while people were using the exoskeletons. Van Herpen reported that during standing from the ground after a graceful collapse, the authors reported that the radiography revealed a fracture of the distal tibia at the tibial plateau with damage to the subchondral bone. On the FDA website, there's 5 tibia or tibial plateau fractures and 2 metatarsal fractures reported. In those studies, no knee bone mineral density criteria was applied for these exoskeletal users. And again, in our study, although it's only 50 subjects to date, we did not have a knee fracture occur during this study. Subsequently, even though the research done by Garland in the early 2000s supported the 0.6 grams per centimeter cutoff, more recently, 2 studies have also supported the use of a BMD at the knee of 0.6 grams per centimeter squared as an appropriate cutoff value to differentiate those who are at the greatest risk of fracture from those who did not fracture. In the past, standard of care for persons with spinal cord injury with ankle or foot swelling has been elevation of the affected joints, or if unilateral edema was noted, a duplex study of the leg was performed to rule out deep venous thrombosis. X-ray or other imaging studies to diagnose fractures have not typically been a component of standard of care for people with spinal cord injury. As such, there may be a relatively large prevalence of individuals with undiagnosed foot fractures in the chronic spinal cord injury population who are at risk of refracture or complications with use of an exoskeleton. In addition to screening criteria for BMD at the hip and knee, we are recommending bilateral X-rays or CT scans of the feet prior to initiating EAW to identify any undiagnosed or healed foot fractures that would predispose the user to recurrent fractures of the feet during normal weight bearing while using a powered exoskeleton. Once we implemented this X-ray, we had no other, we found no hidden, if you will, or undiagnosed fractures in the DoD study, but we also implemented this in the VA cooperative study. And in that study, we excluded 6 individuals who presented with previous foot fractures that didn't know they had them. Our data lend support that persons with chronic SCI who are non-ambulatory appear to be able to safely participate in an institution-based EAW program if screened appropriately for fracture history, bone mineral density at the knee and hip, and by obtaining bilateral foot X-rays or CT scans. Additional work is required to develop more accurate methods to identify criteria for preventing or reducing the risk of fragility fracture during EAW, as well as to maximize participation in EAW to achieve greater mobility and improved health. To accomplish this objective, the strength of skeletal regions of the leg and foot, such as applying finite element analysis or other advanced imaging modeling techniques, and the forces that will be brought to bear at the foot, ankle, knee, and hip joints during EAW for sitting, standing, and walking need to be accurately determined. Lastly, clinicians should remain vigilant for the occurrence of AEs, some of which are as of yet unappreciated that may result from participation in EAW training. So during the past 10 years, the lessons our group has learned is not everyone with spinal cord injury wishes to use one of these devices. Not everyone who wants to use one is eligible. We've already seen that as much as 50% of those screened could fail for various reasons related to extreme bone loss, spasms, contractures, limited range of motion. Distance from the training centers is a barrier. Proper fitting of the devices with the user is critical to prevent skin abrasions. Non-traumatic fractures can happen. Bone mineral density screening fracture history can reduce this risk. With the same training protocol, some people have better responses than others. Exoskeletons appear to be good for therapy and exercise, but remain limited for mobility. People still need a wheelchair. The technology and the FDA require a companion for home use, which can result in a loss of independence for a person who's self-sufficient and living alone with spinal cord injury. Time commitment for training and lack of a companion also limits many would-be users. However, with all that being said, in those who are successful users of these devices, most report extremely high satisfaction. Thank you. So as one can see, we had some early exoskeletons in the early part in the 1934 and 1974. And then this is just a small amount. One person recently told me, an engineer from France, that he had counted over 150 exoskeletons that can be used for people with paralysis that are either being developed or at some stage of development. And I'd like to say a special thanks to all of our participants and Peter Gorman, Gail Forrest, Pierre Aslin, Hannah Hong, Steve Nesvik, Stephen Kornfeld, Owen Tsai, Michael Elliott, Cal Moran, Dennis Doyle Green, Noam Harrell, Jill Weck, John Henrakis, and my colleague William Bauman, who I've worked with for the past 3 decades. Thank you very much.
Thank you, Anne. That was great. Very, really impressive sort of survey of where we've come from and where we're headed in terms of the use of these devices in patients with spinal cord injury.
Yeah.
So what I'm going to do at this point is we will, I think, open this up to our panel discussion. There are a couple of questions specific to you, Anne, and then others that may pertain to other.
Did I stop sharing correctly?
Looks that way.
Oh, okay. All right. I think I just didn't turn it off here. Sorry. Okay, now I'm good. Sorry. Yeah. Okay.
Wonderful. So first of all, questions that have come in specific to you. One question is in terms of the risk of fractures. Do you have enough data that can distinguish between the risks with the 2 devices that you've studied, or perhaps the data isn't sufficient?
Well, we really don't, because we've had minimal fractures, but I can tell you both devices had the fractures. So I'm not sure that one device over the other is more protective or worse. I can't really say at this point. In the knee fractures, though, are also occurring in both devices. It's the forces of that sit to stand that are critical. And so, you know, if the bone mineral density at the knee is really washed out, there is a high risk of that action alone of fracturing.
Sure. And then I think you may have alluded to this, but the sort of clarify in terms of the different devices, it seems that perhaps the EXO provides more trunk control and support than the other device. Is that correct? And
yes, that's what we've found. We haven't tested it with biomechanics or any biophysiological measurements, but we have noticed through observation that the EXO definitely gives more trunk support and stability. It appears to be more of a true robotic device. And, you know, the EXO can have the assistance turned off or turned up, either way, for the stepping action. But overall, it's easier to put the higher cord lesions in the EXO.
Sure. Do patients still need to have some degree of trunk control? So in other words, if somebody really has poor trunk control, can they still train in the EXO?
No, they're not going to be successful users without. We've used a lot of different trunk stability bracing that we've added to help the device for those people, but it's a little harder on them. I suppose if we tethered them, we could, you know, a combination of tethering and using an exoskeleton could give them the opportunity to be upright and walking. And, you know, most of the patients that when they get upright and start walking, they're so thrilled to be upright again and walking that it's a nice thing for them. They want to do that. Yeah.
So one of the issues that you sort of brought up, I think, very clearly is that, many of these people don't have sufficient bone mineral density to safely use these devices. And that's a very disappointing piece of news to people who have spinal cord injury and are very excited, and they hear about these things and they see them. And you screened out half your patients, many of whom were screened out for this very reason or other reasons as well.
Yeah.
Is there any notion of how we can help preserve bone mineral density better in this population so that when they're ready to use an exoskeletal device, that they're able to?
So that's a great question. We recently completed a randomized double-blind placebo-controlled trial at the Kessler Institute where we used denosumab in acute injury, and it was effective. We published that. I believe it's in Osteoporosis International, and it was effective at preventing bone loss and motor complete spinal cord injury. Alberto once told me way back in 2010, 11, that possibly if enough people use these and weight bear early on, that with enough time over time, use over time, we might mitigate some of the bone loss. But it's a real problem. And it's not just the bone loss that's a problem. Patients often sit in their wheelchairs and their knees flop apart, their feet curl under, and then they can't get their feet flat. And so there really has to be a whole education of protecting your lower extremities as best you can. Their foot will fall off their footstool and they'll roll over it and not really care so much, or they'll take their shoe off and let their leg just plop down to the ground. So there needs to be an education of, if you want to use an exoskeleton, these are certain things you're going to need to do to keep you eligible for it.
Sure. Yeah, you could imagine that would be a sort of a standard set of recommendations for patients with new spinal cord injuries to follow to preserve their ability. These devices are only getting better, and
yeah, you want to be able to use one. Many will want to use it and not be screened out.
I would think so. Here's a question for both you and Alberto to maybe address, which is, how close are we really to wider use of these devices? I mean, these are being used now in clinical trials. They look very encouraging. Patients who learn how to use them love them. You really, it's someone who's worked in technology. It's very gratifying to see a device that patients are so excited to adopt. There's so many of them where we maybe are trying to convince them to adopt. But yet you see very few of these in the community, right? I don't think I've ever bumped into someone in Penn Station, who's getting around with an exo. We see people in wheelchairs, but not using exos. So what would it take to really achieve that as the next level in this process, to get it to the point where in fact the community, and I know there are financial and reimbursement issues and training issues, and what are the sort of key things that would be required to get it more broadly used?
Alberta, do you want to answer first?
Happy to give it a try. I think there are 4 items that are critical here. One has to do, as you suggested, the financial part, and I'm going to leave that aside for a minute. The second has to do with the agility of these devices. It's easy to walk on level surfaces, but if you have any terrain irregularity, it does make it harder. Definitely, there are fine-tuning that you can do to the settings to change that, but you cannot do that on the fly. So changing terrains can present some problems. The third issue is walking velocity. These devices still are walking pretty slow. So you pointed out, Joel, that when you go to Penn Station, you see people in wheelchair, is because they can move pretty fast. And doing that in an exoskeleton would be quite cumbersome. It would take you time to go long distances. And then the fourth and final is the fact that these devices are still quite bulky. So it's not easy to wear one, sit in your regular wheelchair, and be able to go places and then switch from one mode to another. So I think that those are important factors that we will see improve as Sunil and others in the engineering world are changing the way the systems work and the size and weight and power availability. And so as that happens, I think that we will see some improvement in that.
Thank you, Roberto. And anything you want to add to that?
Well, the speed is definitely an issue, although it's my understanding that they could walk faster, but it's the stopping that's the problem. That the momentum's going, and you know, we can all stop very quickly if we need to, if a ball rolls across the front of us or for whatever reason, but it's quite difficult. You need a few steps to stop in the exoskeleton. So that is limiting their speed ability. The use of the crutches ties up the hands, so the hands aren't free for anything else. That's a problem, although there's some new technology coming out now with the using the self-balancing, but these devices are pretty bulky at this point. But, you know, it would be nice to see some of that self-balancing, you know, put into the exoskeletons so that the individuals would have their hands free. And so, yes, those are the issues. And training to learn to use them. There's a time commitment. Some people can learn really quickly in 4, 5, 6 sessions. Those are rare, but most people are going to take 12 to 20 sessions to get comfortable in these devices and be comfortable using them without a trained professional around with them.
Fair enough. Thank you. One last question for Preeti, and then I think we'll have to probably close the session. And that is, you know, you spoke of the need to provide more intensive therapy to patients who are most severely impaired, and also touched on the use of telerehabilitation as a means of maybe delivering more therapy at lower cost or without increasing cost. But I wonder if those two things aren't to some degree in conflict, in the sense that the patients who are most severely impaired are also the ones that are going to have the most trouble using some of these technologies because of visual perceptual problems, aphasia, cognitive issues. How do we address that? And maybe there's no simple solution, but do you think that we can help those most severely impaired patients in this way, or do we need to still do in-person therapy for them?
Yeah, great question, Joel. I think, so what we're really doing is this phased approach, right? Where for those most severe patients that you're talking about, they do need the in-person support. They do need the hands-on, you know, and you have to take into account the cognitive, the perceptual issues you mentioned. So I think the standard rehabilitation, as we normally, but as I've seen it over the last 20 years, tends to be, at least outpatient rehabilitation tends to be, you know, twice a week for an indefinite period of time, and we keep trying to increase it. Well, one of the models that we are working on is to try to give higher intensities early on for these more impaired patients. So we're giving them 5 times a week, 3, you know, to 6 hours a day, right? And we're trying to make an argument for it and study to see if that really has an effect. If you can do that for the more severely impaired and you have technology for the less impaired, then potentially you can, you know, deliver the right intensity and frequency for those who need it most, but give it differently for those who can tolerate, you know, who could do better with who could self-manage with telerehabilitation.
So to some degree, to reallocate the sort of in-person resources to those who need them the most, which makes good sense. I like that. Well, very well. I want to thank all the presenters for their wonderful talks, and for everybody for attending. This has really been great, and of course to Sunil for organizing the whole course, which is no small achievement. This has been a challenging time to run conferences, and this one's been run really well. So well done, and I hope everybody has a great evening, and hopefully we'll see you tomorrow at some of the other talks. Have a good night.
Bye-bye. Thank you. Wonderful.
Thank you, Joel.
Talks,
thank you, all the
Sunil.
speakers. Yeah. Thank you. Wonderful talks.
Thank you. Bye-bye, everyone.
Bye-bye.
Bye-bye.